This is Chapter 13, Recording 2. For one rescuer adult CPR, when you're providing CPR just by yourself, you provide a continuous cycle of 30 chest compressions followed by 2 artificial ventilations. The ratio of compressions to ventilations is going to be 30-2. 2 rescuer adult CPR is obviously preferable to 1 rescuer. That way you can actually switch out who's doing chest compressions so you don't get as tired. You can definitely do more effective CPR for a lot longer. Switching rescuers during CPR is critical to maintain high quality compressions. It's recommended that you switch positions every 2 minutes or every 5 cycles. Devices and techniques to assist circulation. Active compression, decompression CPR, so good compressions down, making sure you allow the chest to completely recoil. An impedance threshold device, we don't really use these all that much anymore, so you don't have to worry about that. A mechanical piston device, there's a picture of this on the next slide, you'll get to see that. Loading, distributing band CPR or vest CPR, this would be like a Lucas device if you've seen any of that. But manual chest compressions remain the standard of care because not everybody has access to these new technologies. So here on the left, you've got a mechanical piston device. They're holding it in place and it's actually performing the chest compressions. On the right-hand side, you see an impedance threshold device called a rescue pod. We do not frequently use these anymore, but there are some services that still have them on their repertoire and they do utilize them. But it'll be probably infrequent for you to see a rescue pod. Lucas devices and manual CPR or automatic CPR devices are getting much more common. So you'll probably see one of those at some time or another throughout your career. Infant and child CPR, in most cases, cardiac arrest follows respiratory arrest, which we talked about earlier, which triggers hypoxia and ischemia of the heart. So airway and breathing is the focus of the pediatric BLS. Causes of respiratory problems leading to cardiac arrest are going to be something that you're going to want to know because then you can correct those respiratory problems and thereby correct the CPR, hopefully, or need for CPR. Determine unresponsiveness, so gently tap the shoulder of the child or the foot of the infant and speak loudly if you find the patient is unresponsive, apneic, and pulseless. While alone and off-duty, perform CPR for 5 cycles or about 2 minutes, then call the EMS system. Unless you have a phone that can be placed on speakerphone, then you don't have to wait. Go ahead and call and put the dispatcher on speakerphone so that you can go ahead and talk to them. You want to check for breathing and a pulse. The child must be lying on a hard, flat surface for effective chest compressions. You want to turn the child over and lay them on that flat surface so that it's easier to assess. You're going to assess simultaneously, and it should not take longer than 10 seconds. Foreign body airway obstruction in children is common. If the child is unresponsive but breathing, place the child in a recovery position unless you suspect injury to the spine, hips, or pelvis. 2 common techniques for manually opening a child's airway are modified for pediatric patients. You may need to place a wedge under the upper chest and shoulders when supine. This allows the patient, because they have a proportionally bigger head than that of the adult, if you put something underneath their shoulders, their head is going to naturally fall back into what we call the sniffing position, and will adequately open the airway most often in children and infants. Providing rescue breathing. If the child is not breathing but has a pulse, then open the airway and deliver 1 breath every 3 to 5 seconds, leading to a total of 12 to 20 breaths per minute. If the child is not breathing and does not have a pulse, then deliver 2 rescue breaths every 30 seconds, or every 30 chest compressions. If you have 2 rescuers, this makes it a little bit different. 2 rescuers, you do 15 chest compressions for every 2 respiratory breaths that you give. So single rescuer, 30-2, just like adults. If there's 2 rescuers with kids, then we go to 15-2. If an infant or small child is breathing, then provides prompt transport. Allow the child to stay in whatever position is most comfortable. If a child with a tracheostomy tube in the neck, remove the mask from the BVM and connect it directly to the tracheostomy tube to ventilate the child. A face mask with a one-way valve or a barrier device over a tracheostomy site can be used as well. And we looked at that when we were looking at the adult side. Interrupting CPR. CPR is a crucial life-saving procedure that provides minimal circulation and ventilation until a patient can receive defibrillation, ALS treatment, and definitive care at the ED. No matter how well performed it is, CPR alone is rarely enough to save a patient's life. So keep that in mind. No matter how good you do, they need more advanced care most of the time. If no ALS is available at the scene, provide transport based on your local protocols, continuing CPR on the way. Consider requesting rendezvous en route to the hospital. Try not to interrupt CPR for more than a few seconds at a time, and only when absolutely necessary. Your chest compression fraction is the total percentage of time during a resuscitation attempt in which chest compressions are performed. Try to maintain a chest compression fraction of at least 60%. So this takes into account how much you're on the chest versus how much you're off the chest. Now you have to stop compressions in order to give those good bag valve ventilations. You want to make those as quickly as possible while still maintaining good pressure for the airway. You don't want to just pump air in there like crazy, but you want to give 2 really good controlled breaths. And then you need to be right back on the chest for good chest compressions, trying to make sure that your chest compression fraction is at least 60%. When not to start CPR. So there's 3 general rules regarding when not to start CPR. If the scene is unsafe, your safety is obviously first and foremost the priority. So if the scene is not safe, don't start CPR. If the patient has obvious signs of death, which include an absence of pulse and breathing, it's more so along the lines of if there's rigor mortis, if there are injuries that are incompatible with life, such as a decapitation, or if the patient has dependent lividity. So when you die, your blood goes to the lowest point in your body. It looks like a big bruise most of the time. If the patient has that bruising called dependent lividity, then you don't have to start CPR. The third way is if the patient or physician has previously agreed upon a do not resuscitate order and they can produce these orders for you. You have to actually see the paperwork in order to not start CPR. If they say they have it, but they can't produce the paperwork, then typically you're going to start CPR and then you'll stop. Once you begin CPR, continue until one of the following occur using the mnemonic STOP. S, the patient starts breathing and has a pulse. T, the patient is transferred to another provider of equal or higher level of training. O, you are out of strength. Or P, a physician directs you to discontinue. Out of strength does not just mean tired, but physically unable to continue. And if you do CPR for long enough, you will get there. CPR is extremely labor intensive. And so you're going to get out of breath very quickly. You're going to get tired very quickly, but you want to go until you physically cannot continue anymore. Foreign body airway obstruction in adults. This is one of the main causes of airway obstruction. In adults, foreign body airway obstruction usually occurs during a meal. In children, it can be from a meal or it can be when they're at play because kids love to put things in their mouths. A mild airway obstruction, the patient is still able to exchange adequate amounts of air but has signs of respiratory distress. Don't do anything for patients with mild airway obstruction. You want to observe for signs of severe airway obstruction. If the patient is coughing, you want to go ahead and encourage coughing as well. In a patient that are responsive and have a sudden severe onset of obstruction, it's usually easy to recognize in responsive patients because they do the universal choking sign, putting both of their hands at their neck. If the person is suddenly unable to speak or cough, grasps his or her throat turns cyanotic and makes exaggerated efforts to breathe, then you know that they have a sudden obstruction. Stridor may be present. Stridor is a whistling sound where air is trying to move around the obstruction. If the patient is unresponsive, suspect obstruction if maneuvers to open an airway and ventilate a patient are ineffective. Removing a foreign airway obstruction, abdominal thrust maneuver, also known as the Heimlich maneuver, is recommended in responsive adults and children older than 1 year. It creates an artificial cough, so it uses forceful air up against the object in order to try and dislodge it. If the patient with a severe airway obstruction is unresponsive, then perform chest compressions. Instead of the abdominal thrust maneuver, use chest thrust for the following patients: women in advanced stages of pregnancy and obese patients, because they are not going to be able to produce that effective quote unquote cough. So here's on a pregnant lady giving her chest thrusts instead of abdominal thrusts. So in unresponsive patients, you want to determine the unresponsiveness, make sure that you tap and shout and try and get them to respond to you. Check for breathing and a pulse. If a pulse is present but breathing is absent, then open the airway and attempt to ventilate. If your ventilations don't produce visible chest rise, then reposition the airway and reattempt to ventilate. If both ventilation attempts do not produce visible chest rise, then perform 30 chest compressions, open the airway, and now you're going to add looking for the object. Attempt to carefully remove any visible object. We don't perform blind finger sweeps anymore. So if you see an object, try and get it out. If you don't see an object, continue to do your cycles of 30 to 2 for chest compressions to airway breaths. Foreign body airway obstruction in infants and children. Airway obstruction is a common problem in infants and children. If the patient has signs and symptoms of an airway infection, do not waste time trying to dislodge a foreign body. Administer supplemental oxygen if needed and immediately transport the child to the ED. As long as the patient can breathe, cough, or talk, do not interfere with his or her attempts to expel the foreign object. Administer supplemental oxygen if needed and tolerated, and provide transport to the ED. On a responsive standing or seated child, provide the Heimlich maneuver, but with less force than that you would use on an adult. In an unresponsive child older than 1 year that has an airway obstruction, you're going to remove it the same way that you would for an adult. So here's how you would perform chest compression. So getting down to a knee to the level of the child, if you can. In infants, you're going to provide back slaps and chest thrusts or chest compressions. In unresponsive infants, begin CPR beginning with chest compressions. Do not check for a pulse before starting compressions. Open the airway and look in the mouth. If you see an object that can be easily removed, then remove it with your finger and attempt to ventilate. If you don't see an object, then resume chest compressions. Continue the sequence of chest compressions, opening the airway, looking inside the mouth for the obstruction, and removing it if you can. You want to do this until it's relieved, the obstruction is relieved, or until your ALS provider takes over. And this is what back blows and chest thrusts look like in an infant. And like I said, you'll keep going until the infant is relieved of their obstruction or until ALS arrives. And we'll go ahead and stop here.